Okay, well, we'll give it a minute while it loads up there. So part of the reason that I'm here is Phil Rendazzo and myself work with Professor Scott O'Neill from Monash on the Eliminate Dengue program that you're so instrumental in here in Yogyakarta. And so we've been supporting Dr. O'Neill and Monash in terms of his lab and the effort to start the research. And then we've been really fascinated and really excited about the effort and the progress you've made here in the implementation of this research in your own community. And so for us, it's an opportunity to come and study what you're doing and to learn from you and how you're implementing this program in a way that we could potentially use to help advise other places in the world. And so once my presentation pulls up, hopefully we'll be able to and a big focus on data and making informed decision making. And that's a big part of what our group is trying to do. I have the fortunate opportunity to work for a tremendous foundation that has a lot of financial resource that can do lots of good things. And one of the things we have to be very careful about ourselves is measuring what we do so we make sure we're doing the right things and that we're spending the resource in a way that's positive and beneficial for people. And so that's a big part of what my group does. If our projects are not helping people in your community lead better, healthier lives, then we should be redirecting what we do. So let's talk a little bit about progress in the communicable, maternal, neonatal, and nutritional disorders. This is a graph that's kind of an interesting shape. Let's see if that'll, is that? No, okay. Oops, sorry. Let's go back. So this graph, what you see here is a rectangle, and in the rectangle there's different shades, and each of those different shades represents a different disease. And what those squares represent is that particular disease in 1990 in that region of the world. So here in South America, so Latin America, Caribbean. This is essentially the impact of it, or measured in DALY, so the disability adjusted life years. So the years of life lost to disability because of these illnesses in 1990, and then for that same area and the same illnesses in 2010. And you see the blue hatched region, that's the old outline or output of the percent of death. So the square has reduced. And overall, all of the squares have reduced. That's tremendous progress that's been made in those 20 years in terms of these diseases. Now when we compare it to a place like sub-Saharan Africa, first thing to notice, the square is larger, okay? So that's actually representational in terms of numbers. And the reduction in 20 years, very minimal, right? I'm sure that I apologize, I don't have a slide for your region of the world, but my guess is that if we looked at your region of the world, it's going to look a lot more like this and a lot less like this, right? But there are still places that need a particular amount of help in the communicable, maternal, and neonatal and nutritional disorders. And one of the things we try to do is measure those outputs so we know that we're moving in the right direction. So what we focus on in global health are what we call the areas of greatest need, where we can have impact. That's one of the things that's been important for us to recommend or understand. We can't do everything. And even the things that we try to do, we don't always do as well as other people. So Tim, who's with us here from the Wellcome Trust, one of the things that we try to do is work together with the Wellcome Trust or work together with the local foundation, the Tahia Foundation, to be able to say, what is it that you're doing well? Because if you're doing it well, we don't need to do it. That would be wasted resource. Let's instead support other things and work in partnership with you. Let's work in ways where our work complements your work. So we try to identify these areas of greatest need and then where we particularly can have the greatest impact. And our goal is making what we could say science happen for the benefit of people. And one of the things I want to express to you today is that science and research and innovation has a broad place to be applied. Okay? I think we tend to think of it as what goes on in the laboratory, what's really basic research and really, groundbreaking, cutting new research. That's really important, but if that work only stays in the laboratory, it doesn't have impact. It might get you promoted, You might feel good because you got a paper and, or you got your PhD approved, right? And you can go on from there. But remember, what we're trying to do is we're actually trying to impact people's lives, right? We want to help people. And so partly if our work doesn't get out of the laboratory into the field, into the hospitals, into the hands of patients, it's really not achieved the impact and the benefit that we're trying to reach. We have a tendency to use a lot of abbreviations. So BGF stands for Bill and Melinda Gates Foundation, is a global organization that's structured with two main global areas called global health and the other called global development. And between those areas, we share what we call program strategy teams. So those are all the different areas where the Gates Foundation is involved in global health. So these are disease-focused areas. The gray ones are what work mostly in global development, and they're in global development because the biggest challenges that are present right now are actually delivering effective services to people in need. The blue are in global health, and there they have both the challenges of basic research as well as delivery aspects to people in need. And then, here comes the fifth version of my application. Okay, there we go. And then along the side here, what do we call functional areas? And these functional areas support all of these different strategy teams. So here I've circled one called Integrated Development. That's the group that I'm a part of. And Quantitative Sciences sits in Integrative Development. We also have a Regulatory Science group, a group called CMC, or Chemistry, Manufacturing, and Controls, and a group called Diagnostics. Okay, back. Phil Randazzo's group is Discovery and Translational Sciences. So they work on very early discovery phases, funding Scott O'Neill's research as an example. And we work together to help support all these different areas. So the most exciting thing about my job is that every day I get to work on a new disease. The most challenging thing about my job is that every day I get to work on a new disease. So today it's malaria, tomorrow it's dengue, the next day it's TB, the day after that it's HIV, right? So there's a lot of challenges in trying to keep those, the challenges of those particular diseases. Intellectual thing for me. So even when I was a professor, this job, I have more homework for this job than I've ever had for any job before, because there's a lot to learn. But one of the things that I try to bring in our groups in these functional areas try to do is say, what are consistencies that we see across these diseases? Because I think there is a tendency to say, I'm a malaria researcher, so I only work on malaria, right? I'm dengue. Don't talk to me about malaria. I do dengue, right? 80s, not anopheles, right? And so tendency to do that, and when we do that, we miss opportunity, right? Opportunity to see what are the consistencies, what are the patterns where we could learn something from malaria and apply it to pneumonia, right? So what are those challenges and those opportunities? It's probably like each of the 5 options opening up. So those are part of the interesting challenges of what we try to do in our program. And our goal, right, is to have what we call an integrated approach for global health. And I have to admit that we weren't, we've been in a foundation in existence for 15 years, and when we got started, like all good things, right, you get started, you go identify problems, and you go run at them and try to solve them. And the problem is we ran at them in 6 different directions rather than running at them in a concerted direction together. And one of the things that we're trying to be careful of is that we want to approach our problems not as trying to deal with people who have a disease. We can find big, impactful solutions, and I think the Wolbachia project and the Eliminate Dengue project here in vector control has the potential to be very groundbreaking. Vaccines, also very groundbreaking, right, because they can eradicate a disease with a vaccine. So these can be tremendously impactful, and when we integrate them all together, then I think we end up with solutions that potentially can stay and be more resilient over time. These are some of the compounds that we work on across all the different phases of development. So here is research. Out here is post-approval launch in the community. And these are the different diseases that these compounds represent, broken down by color. And I just bring them up to show that we're looking across the broad range of challenges in terms of drug development. And also to mention one thing. We don't do anything ourselves, okay? The Gates Foundation, we don't have any labs, right? I have an office. It's kind of small. But we don't do any of the work ourselves. We partner, okay? We are enablers of the work to be done. So we don't stand there and say, the Gates Foundation did this. What we do is we partner with people who go. All of our work is through partnered impact. If we don't work well, we will not have impact. And so that's one of the things that we're trying to really continue to think about. So we have a broad portfolio, if you will, of drugs that are being developed for a number of different diseases here that you see in the circle, and our team supports and helps those projects in ways that they need help. Sometimes they don't need any help, and then our best support is to get out of the way, right? But sometimes they need technical assistance or guidance where our team can actually help and contribute. So one of the ways that my group works is on to support drug development. So we have a team of mathematical modelers, much like, you'll recognize this is fake, right? So this used to be Florida, and this morning I changed it to Bali, okay? In the United States where I live, every year there's a hurricane season, and here you're going to have typhoon seasons, right? Or cyclones. And so there's always a concern about if you live in the path of the storm, where is it going to come? And so we have lots of historical data where we've built mathematical models that describe the behavior of weather, where we can predict and forecast, okay? We can't assert, right? We can't say the storm's going to go here. We can just say, based on what we know in the past and what we see going forward in the data, the storm is likely to follow this path. And if you're on this path, you might want to do some certain things, right? If you're in these areas, you might change your behavior, right? And so partly it's trying to use mathematics to model and simulate the experiment we're trying to do, in this case, the use of a drug to cure or treat a disease, and to explore, are we on the right path? If we're on the right path, great, let's keep that dose where it is. If it's not on the right path, how do we adjust it? And one of the challenges we want to look at is not assume that one dose of drug works well for all people, right? So we do a lot of analysis of data from clinical trials to say, do women behave differently than men? Do people who have a certain genetic metabolism profile look different than others? Do people from Northern Asia who eat a diet different from Southern Asia have different responses to these drugs, right? So how do we build all those pieces together to inform decisions? So a good example is just the difference between children and adults. If you spend any time in looking at drug development, most of drug development that's driven for commercial profit is geared towards us, right? Well, older adults, I'll say me, younger people as well too, but not really for children at all, for a number of reasons. First of all, children are challenging, they're growing and changing over time. But one of the things that's really interesting to look at is just this. This is the distribution. It's a relative percentage of your body that's made up by different tissue components when you're a young child versus when you're an adolescent. And one thing in particular is the fat content, right? The fat content when you're a little baby is much higher than when you're your age. Now, when you get to be my age, it might revert, but so it's the fat content is larger. And notice also that the fat is made of different things, both lipid and water. Here, lipid and water, but to different proportions. Those kinds of seem small and subtle, but they can have a big difference in the concentration of drug you get in the body when you take a dose. And so appreciating those differences, learning how to scale from the smallest child up to a full-grown adult is really critical to being able to pick the right dose for a new therapeutic. Okay, let's go. All right, there. So let me give you an example. And this is one we're working and looking at results long after the innovation had been developed and been out in the field has been helpful. So this is on the y-axis. This is the total dose of a drug divided by kilograms, and the drug is lumefantrine. Lumefantrine is of the very successful anti-malarial called Coartem, or lumefantrine combined together. And lumefantrine is the longer acting of the two agents. And here you see different categories. If you're under 1 year old, a little older, a little older, a little older. But one of the things you notice is the milligram per kilogram amount is higher in the youngest group. Okay, so notice it's higher in the younger group than in the smaller group. So that's kind of good in the sense that, well, as long as the drug is safe, right, we're giving a bigger overall milligram per kilogram dose. There are some outliers here, right? There are some kids that are different, so it's important to keep that in mind. So that would make you think, maybe it's a right therapeutic. This is actually a picture of 6 pills over 3 days, so twice a day for 3 days. And the pills are solid pills. It actually comes in a dispersible, so we can drop it in your glass of water and it just dissolves, and then the key is to get the child to drink that drug. But notice here what we're looking at now is down and then going back. Bars here. There's a darker bar and a lighter bar. The darker bar are kids who are underweight for age. Okay, so they're kids who are lower in body weight for their age. Could be for a bunch of reasons, but we're assuming that's a surrogate for they're malnourished. Okay, so kids who are having food restriction, don't get access to good food, they are looking a little bit different. Well, that makes sense, right? Because they're smaller. So their denominator is smaller. And so they look like they're getting an effective dose. But now, let's see what happens when you actually look at the data. When you look at the concentration after they finish, underweight for age. So again, a surrogate for malnutrition. Not precise, but this is a retrospective analysis, so we don't have any better information than that. We start to see that the kids that are underweight for age are actually underexposed compared to the kids that are normal. So isn't that odd? On the one hand, you would think their milligrams per kilogram is bigger, so they should be getting an effective dose. But when we actually look at their day 7 concentration, how much is actually in their body, it's reduced compared to kids their same age who are normal body weight. And so one of the things that's giving us pause is that we may be actually underdosing malnourished kids with this antimalarial. And that would be an important thing to understand. This is from an analysis of data that was collected over the course of 15 years. So it's almost, I think, in total, this study had about 7,000 individual children's data from studies all over Africa and also Southeast Asia, where we massed and pooled all the data together. I say we. Actually, it was a collaborator, the Worldwide Anti-Malarial Research Network, based out of Mahidol in Bangkok, in Thailand, and analyzed the data to see that children who are small and who have at least some degree of growth stunting or malnutrition are below the therapeutic concentration on average. That means we're undertreating them, and we have to think about whether we can dose them better. It could be that when we drop the tablet in the water, right? How many of you have small children? No, a few of you do, right? Okay. Yeah, so you're trying to feed a small child this amount of water, okay? How much ends up in their mouth and how much ends up on their shirt, right? So we're good at dosing their shirt, but maybe not dosing their mouth. So it could be some reasons for that, right? But you would do the same whether you're small or not. One of the differences, anybody ever take Coartem here? No? I've taken it once. It's not a very pleasant drug to take. In fact, it's very difficult to absorb. And so it could be that children who have already disrupted intestinal function from malnutrition may not be adequately posed to absorb the drug. And so then the response might be, we maybe should treat them with a different drug, right, rather than try to adjust the dose. So these are important pieces of information. You start so you can synthesize data together. If you asked any one individual investigator who contributed data into this trial, could they find this relationship? Probably not, because the trials are too small. So these are some of the characteristics of what we get involved in. Sometimes simple things like the fact that your dose in milligrams per kilogram is going to change depending on your tablet formulation. Formulation can have a big impact in success. This is data from Anya Turlo, who's based in a medical facility in Malawi. And these white lines here just represent the target concentration that you're trying to achieve. This is for the anti-malarial amidiaquine. And notice that I have a quarter of a tablet, or a half a tablet, or a whole tablet, depending on what age I am in. Then, on average, I get in the target, but some kids are below, and some kids are above. And what you generally see is, if you're on that transition, let's suppose we say, okay, if you're up to 7 years of age, you get a quarter of a tablet, and then all of a sudden when you become 8, right, so on the day before your 8th birthday, you get a quarter of a tablet, and the day after your 8th birthday, you get a half a tablet, okay? So what happens? You go from being low exposed to being high exposed. And part of it is, we just can't make enough size tablets for all the different kids in the world. So we try to optimize the formulation in a scenario that brings all of these dots as best as possible into this white target line, right? So that's an example, a great example of where great drug, good clinical efficacy, but putting it in the right package to deliver it effectively to people is actually a big determinant of success or failure here. Okay, so if we can't get the right dose into children, then our opportunity to treat what they have is going to be greatly limited. One of the ways we've been exploring it, so not to say that it's only all in delivery, is to come into some novel research. Here's just some pictures from a publication that was recently in Nature Materials. And our collaborator, our partner we work with, is a gastroenterologist named Giovanni Traverso at Massachusetts Institute of Technology. And he's created these little drug tubes that swell when they get in your stomach. So you can take them, stuff them in a tablet, swallow them, and then they can expand. And as they expand, then they can change their properties in terms of how they release the drug out of the design, and then how they actually change shape over time. So here actually what you're seeing is this is the pictures of the drug system after up to 14 days that it was in the intestine of a pig. And so it can change shape and then vary its delivery profiles. And essentially the idea is that you can create these different shaped components, and each one of these arms, for instance, I call this the drug starfish, or maybe here we call it the drug squid, right? And then we can fold it up, stuff it into a capsule, and swallow it. And it's interesting to watch this form, because one of the things that he's a physician who treats people with intestinal diseases, but also treats children who swallow things they shouldn't swallow. So he understands a lot about how things move through the intestinal system. And so he's created shapes that tend to stay longer in the intestinal system. So profiles, because the drug is lasting in the body longer and has this opportunity to essentially produce the kind of exposure that we want, that, if you think about what I showed you a minute ago, would keep every child in the target lines there. Okay. For S.C. Johnson mosquito repellents and a number of different products. And one of the things that we've learned from working with them is they spend a lot of time understanding people. So just, I'm probably, the challenge of malaria. There is malaria in Indonesia. There's not malaria in Yogyakarta, I'm told, which is good because I didn't prophylax for malaria, so I hope that's true. And Dengue, yeah, that's what Scott said to me. Plenty of dengue, no problem with malaria, right? But there is Vivax malaria out in different parts of Java, of course. And so there's 200 million cases of malaria a year, 627,000 deaths. And so it's really a serious problem that we're trying to work on in some preventable way. And here you see a series of pictures that show some of the technologies. And this is actually from a trip that we took with the S.E. Johnson team to Thailand and Myanmar to not assume we know the answers of what people in Thailand and Myanmar want to be able to work with combating malaria, but instead to ask them to look at the solutions that exist currently. So here you see a picture. This is a rapid test, right? So the nurse, when you feel like you have a fever, she'd come in, prick your finger, do a rapid blood test, positive or negative for Vivax or falciparum malaria. Here, of course, is the coartem we just talked about. Bed nets as technologies. This is just mosquito cream, okay? A lot of people don't like to use mosquito cream. It's partly because of the chemicals. And then these are all pieces of information and literature from the health workers in different parts of Myanmar and Thailand. So this is helpful for us to see what are the pieces of technology that people have. How do they use them? Do they like to use them? Do they not like to use them? Anybody sleep under a bed net before? I had when I was there. It's awful, right? It's hot. It's really hot. You know, geez, like although the wind should be going through. No, you feel like you're getting wrapped up in a cocoon, right? So really effective, tremendously effective. Bed nets and their impact on reducing malaria mortality, particularly in places where you have indoor biting mosquitoes, right, has been phenomenal, but not really a great solution from the standpoint of comfort and use by people, right? So that's one of the challenges that we're working with this team, is to figure out, can we come up with better approaches? One of the things that S.C. Johnson does is they go and ask. They sit down with users and say, what do you not like about bed nets? What are the challenges that you have in dealing with malaria? You know, similarly, I can imagine you can do the same. What are the challenges you have with dengue? Not that we assume that we know what the answer is, because our tendency is to come at things with a technology, right? And we say, aha, we have the answer. Here it is. It's in this box. Just take this box and you'll be fine. And people look at it and go, what am I going to do with that, right? I don't like that. So partly we're really focusing on what are users' needs and asking them, looking at where they live. What are the challenges that exist in their house structures? Where they work. This is a rubber tapper. And you know, it was interesting because when I first joined the foundation, we were talking about the challenges of being able to provide solutions for rubber tappers in particular. And I asked people, well, how many trees does a rubber tapper tap in a night? And it's, 1,000 trees easily. And so I had this image of 1,000 trees all in a line, right? And that, gosh, that's a long distance to cover. And then I went to a place where there's a rubber tree grove, and I counted the number of trees and the number of rows and realized, there's 500 right here in a space that's probably, 4 times the size of this classroom. So space is a different constraint when you think about it in those terms. When you see it first for yourself, right? That changes your perspective. That's part of the reason why I like to come to Jakarta. I want to see what you're doing. I want to understand how you're using technology to solve problems. And then talking to people to understand what are the limitations or the issues that we need to be aware of. Because if we don't do this, our probability of helping to create something that's going to be successful that people use is very low. So that's one of the challenges. So this was an interesting, we went and spent, before we went to both of these countries, we had a brainstorming session and came up with 111 different ideas. And then we went to Thailand and Myanmar, to different villages, talked and interviewed with different people that have these different backgrounds, and then came back and created another 208 ideas based on conversation, just on things that we saw from discussing with people and that they told us. They weren't all our ideas. It was also ideas from folks that we had spoke with. Here's just an example. They capture these vignettes about people's existence and the challenges that they deal with so that we can understand those better. This is a lady who's a mother who goes out to harvest mushrooms in the jungle. So her biggest challenge is she doesn't have malaria where she lives. She has malaria where she works. So how do we protect her when she's at work? She doesn't need to be protected to the same extent in her home. And challenges of when you get sick, right? You have to spend a lot of your resource that then competes with buying food. You have to travel to the clinic. You might not be able to go to work. There are all these secondary that come in that contribute to what I'll call the system disease, right? And again, these things, our probability of successful solutions really goes down. So we really always need to keep this in mind when we're working on really good technical solutions. It's not enough just to have the technical solution. And then speaking with the nurse who ran the clinic, what are her challenges in dealing with people? This gentleman was very interesting. So he's a rubber tapper, and he had his own solutions for dealing with area. So one is, that's what he carries on his back. So anything we want to create for him has to be other things he's carrying. And he tended also to, let's see if one more time. He smoked cigarettes. So his solution was, he'd light up a cigarette and he'd blow smoke over his body. And that actually, he found, worked pretty well for about 5 minutes. So about every 5 minutes, take a puff of a cigarette and blow it around on his body, right? So, you know, you all of us, everywhere we go, people are creative, people are innovative, right? They are, but they're just sometimes constrained by what they have available to them. The key for us is to understand that innovation and then think about how do we use that to apply to the problems that we're trying to solve. So this is what some of the ideas that we came up with, that we put into this table, and then we started to just search them around by different themes. See if the computer comes back on. But basically as a way to come up with, you know, how you can explore different kinds of ideas. This is a Buddha poster in Thailand for people to put in their shrines. And then we could group them and break them up by different themes and just always then look and say, what are the right solutions? And this is part of that whole analysis process that we did in combination with the S.C. Johnson. But it's a tremendous way to be able to capture the information and the insights that you gain. A lot of them are crazy ideas, just crazy ideas that you would never do, you know. But that was part of the fun of the exercise. There's no limits, right? This was actually a good one, right? That was a very good one. We had, that's my drawing. It's not very good, right? And so just to bring them together, then group them around themes. Say, what's the story these themes are telling us? Because if you find that 5 or 6 different people are coming up with a similar theme, then you might be onto a solution that's reasonable. So this is a tremendously creative process that we did and had a lot of fun doing it. But you know, it's not only the sole purview of groups like ours. You guys could do the same thing if you sat down and said, well, what's a problem we want to solve? And everybody got a little sticky note and wrote them down. We were fortunate we had a really diligent photographer who took pictures of everything for us to do this. But that kind of process of working together in teams to co-create is a real big part of what they did. And then this is a clever way, I liked how they displayed this. So these are different groups that we decided we'd work on projects for. One is migrant workers, the other is mothers and children's. And the circles represent 24 hours of the time clock, okay? And the dark circles are when it's night, and the light is when it's day. And then if you see a blue line or a red line, that's where we have a product idea that would protect that person during that part of the day. Now, ideally, it'd be great if we had one 24-hour. We'd call it Wolbachia, right? But in this case, we don't, so we have to piece together different components. But that might not be so bad, because remember, if a mom really only needs protection when she's in the forest picking bamboo and mushrooms, then she may not need protection at night, right? And so this allows us to get a sense of what products would fit into what area, and do we have gaps in particular? Are there places during the day when this worker is at risk and we don't have a solution for them, right? And so this has been a process that's really been enjoyable to work on. But the key is that we're merging this product development process with what we call co-creation research. And co-creation research means we're doing it together. It's not me. I don't have all the ideas. You have as many ideas as I have. You probably have more, right? And so for the key is how do we work together so that I get your good ideas, you get some good ideas, even the crazy ones, and from that we come up with a new idea that can solve a problem. And you know, again, we spend time in the field and eventually get to go to nice places too. So I went to Borobudur yesterday, so that was really great. I really appreciated that. So, working with the folks who are experiencing the challenges. So, I want to just tackle 2 more things quickly. What's our time constraint? We're okay? Okay. Okay, so I tend to think about innovation as being focused on what we create in the lab, the new great experiment that we see under a microscope, right? But actually in global health, there's a lot of different things. So one thing that's happened in the last 10 years, the number of people manufacturing Gavi-funded vaccines has doubled. Okay, innovation is created because places, maybe in Indonesia, that didn't have a vaccine manufacturing facility, created one. An opportunity existed, and now things have doubled, and that's actually then means you can get these solutions out to more people, be more effective. Okay? The additional children immunized with Gavi support at that same time period has been 370 million. So that's phenomenal impact. That's really phenomenal, right? And the cost has dropped 36% to fully immunize a child with these 3 vaccines, pentavalent, pneumococcal, and rotavirus vaccine. So those are innovative things. They're innovative things in manufacturing, in delivering, in access, in market forces that then help get the solutions to people who need them. If you just look at rotavirus, and rotavirus vaccines were $7.50 a dose. One of the things that we look at, if we're going to try a new project with a partner and invest in something, we ask, what do you think it's going to cost? Well, when we started working on rotavirus vaccines, we knew it was going to be expensive to begin with. But solving the cost issue was going to be the second stage of the research. So there's a technical part to coming up with a vaccine. Okay, now we have a vaccine. It costs $7.50. That's not sustainable for the places where we're vaccine. So now let's add the innovation to reduce the cost. And in 2012, the cost dropped to $2.50 a dose. And in 2015, now it's where we'd like it to be, which is $1 a dose. All right, so those are innovative things. They don't get written up in the big science magazines. You don't get a Nobel Prize for dropping the cost of vaccine from $7.50 a dose to $1 a dose. But I would argue you have as much impact, maybe even more, by doing that, because more children then get access to your technology. And one of the challenges we run into is that, people come here to Indonesia to do research, they measure things, they take their data, they go back to Oxford or Cambridge or wherever, and they work on their data. So scientists need to be able to share that data in ways that are going to be helpful and beneficial to everybody, particularly the places from where the data comes from. I've had a lot of problems with this idea of data ownership, right? Researchers who say, I own the data because I collected it. And I argue back that actually the person you collected the data from, that's who owns the data. You're the caretaker of the data. You have been given the privilege of being able to have access to it. Your responsibility with that privilege is getting the maximal amount of information out of it you can as quick as possible. If you can't do it fast, get another group of people to help you so you can. So we've been really working on trying to promote science as an open enterprise while respecting very important characteristics. One is privacy of individuals, and second is sovereignty of countries, right? Because Indonesia's data is Indonesia's, right? And so how do we work with Indonesia so that as Indonesia learns about how to ramp up the Eliminate Dengue program in an effective way, we can use what we've learned, what you've learned in Indonesia, and help apply it in other places of the world, right? How do we allow and enable and accelerate the opportunity that your knowledge can help inform and teach the rest of the world? Because in fact, you're ahead right now in terms of rolling out this program compared to a number of other places. So we're really trying to raise the profile of data sharing and get data sharing among different individuals much greater, much more successful. So here are some initiatives that we've been involved with, some with the Wellcome Trust, some with other funders in terms of research capacity where you share data as a fundamental principle. And the key to doing that is that then learn from the bigger story of all of the data rather than a small story that's only told by a small section of it. Challenges was just the lack of the ability of groups to share data, to learn in a very fast-paced condition. Ebola, just explosive, right, as an epidemic. And so how do we learn what's happening and working well with people who are being treated in Sierra Leone and help get that information to people in Liberia? down some of those barriers so that we can efficiently and effectively do that. And one of the key things that we learned from this lesson, and it's particularly poignant actually, was that you don't solve these problems by flying in to the rescue, right? And magically helping them to go out. I mean, that can help. But you actually solve these problems fundamentally by building health systems up from the bottom up and then ramping up their capabilities when they need it. A great example that I don't think has been written up very much, but when there was an individual gentleman who contracted Ebola from his sister, I think in one of the 3 Western African countries, and then he went to Lagos, Nigeria, where he and infected healthcare workers in Lagos and potentially a number of other people, right? And because Lagos is a huge population, right? And so, what happened at that time is the Nigerian government stopped their polio eradication program and pulled all of their polio eradicators into Lagos to do contact tracing for the individuals who were exposed. So they took a piece of their healthcare system, remobilized it, and applied it in a particular way where they identified all the individuals who had actually been in contact with this person and minimized the spread. If you remember, there were maybe 7 cases, I think, of Ebola in Nigeria. But had Ebola not been brought under control in Nigeria, that would have been just disastrous as an explosion, right? And so that's the lesson, is that how do we build the fundamental capabilities in the places where these conditions are going to happen so that they can accelerate them instead of having to drop in success at the last minute, because that's going to be a challenge. So I'll leave you with just the picture from Seattle. We would come to the visitor center and visit us. It has displays about some of the things we work on. It has our mantra there on the wall that every person deserves the chance to live a healthy, productive life. I hope today that I was able to give you a sense of how we're thinking about these problems, how we try to approach it, and I thank you for your time, and I'm happy to take any questions if you have any. Thank you.